All right. So this is lecture number 3. What we're going to do is start off with a review of last week's lecture, go over some questions, and just go over some big concepts of what I thought was important from last week's lecture. We're going to try the polling feature this week. I think we got to figure it out. So the first question is, what type of fracture pattern is this? We're looking at the distal femur. Let me see. Can you guys see the poll question?
Do I get to vote, Jeremy?
Yeah, why not?
Oh, sweet.
Also, while you're looking at this, I think the next question is just think about what we talked about a displacement as well. All right, we're got about 70% voted.
I didn't even read all the answer choices.
Are you the transverse here?
Yeah, I wrote transverse. Yeah, definitely.
All right. So let's see. Can you guys see the results?
Yazin asked if he owed somebody money. I think no. I think that if he owed somebody money, it would either be transverse from a baseball bat or it would have a bullet fragment in it.
So the majority of you guys got it right, 86%. It's comminuted. A couple of you guys picked segmental. I can see what you mean, how you can see there's a fracture line here, fracture line there, but the majority of it's just multiple fragments. In comminuted fractures, there's going to be multiple different spots. So I can see how that confused you.
So, but what I would add is segmental is not wrong. This is just a deeper classification of a segmental fracture. It is segmental and comminuted.
Yep. All righty, let's go on to question number 2. Oh, so then also, like I said, we're thinking about displacement. We would also say that this is in recurvatum because looking on the lateral, this is the anterior aspect. You can see that it's apex posterior, so that's recurvatum. And then when you look at the AP, it's in slight varus, as in this is the medial side, and you can see that it's going towards the body a little bit, towards the medial side, so it's in slight varus. Alrighty, question number 2 is, what would you do, how would you treat this?
Oh boy. We'll see if people's answer choices would change after my lecture today.
Exactly what I was thinking. Alrighty, so let's see the results here. So the majority of you guys, 81%, said bridge plate, and that's exactly what I would think too, because you want to kind of span that area of comminution and allow it to heal.
The reason you can't go for any type of rigid fixation like lagging this is because there are so many fragments, it's impossible to piece it back together. You can't squeeze each of those individual fracture lines, so bridging it is a better option.
And so if we're doing bridging, what type of mode healing do you suspect, and what kind of stability do you suspect? Whenever you hear the word bridge plate, you should be thinking this type of healing and this type of stability. And you guys are doing an awesome job. 97% went with the correct answer. Secondary healing with relative stability. Like Joe was just mentioning, you're kind of distributing that strain of each fragment over this far working length, which is between these two screws. And you're going to start getting secondary healing, which is a bunch of callus formation. And that's what you expect when it starts to heal. So, you know, again, just to go over it, direct bone healing, we're looking for absolute stability where we compress across it and look for a very stiff concept. So examples of this is going to be your lag screw technique with a neutralization plate or compression plating. And then when you're dealing with secondary or indirect bone healing, you want a little bit of motion, and that's going to give you relative stability, and that allows for callus formation. And examples of this are bridge plating and what we just saw in the last x-ray and question, and then intramedullary nailing, which is going to be the focus of this lecture. Alrighty, let's go on to question number 4. So in a lag screw by design, what do you have to do to allow this to function correctly? Do you have a partially threaded screw or a fully threaded screw? And then are your drill sizes the same on the near cortex as the far cortex, or is it different on the near cortex versus the far cortex? This question, the next question is a little bit more technique driven and a little bit more complicated, high level. But I think you guys can take a stab at it and we can go over it. Alrighty, let's see the results. Alrighty, so 51% of you guys got it correct. It's a partially threaded screw with the same size drill holes. And so if we go to this here, so when we're talking about lag by design, the word design gives it away that the companies manufacturing the screws are designing it to be a lag screw, rather than lag by technique is the surgeon is doing something to make it a lag screw. So a lag by design is always going to be a partially threaded screw, and you first drill the near cortex with the same size diameter as the far cortex, and it's going to be able to engage these screw threads on the far cortex and allow the smooth shaft to glide through that same size drill hole. And so then the far cortex, once the threads engage, that's going to pull the far cortex towards the near cortex, and the screw head acts as a buttress and prevents it from sliding, and it allows for compression at the fracture site. This is opposed to a lag by technique where it's a fully threaded screw, but to allow for this near cortex to slide, you have to make a larger drill hole. And so you make a larger drill hole first, and then you make a smaller drill hole on the far cortex. And then when you place your fully threaded screw, the screw threads are not going to engage the near cortex. They're only going to engage the far cortex, and therefore allow the far cortex to come towards the near cortex and cause compression at the fracture site. And then just a reminder that you have to, when you're doing either lag by design or lag by technique, you want to have it perpendicular to the fracture site so you don't allow for any shear when you're compressing. Joe, you have anything to add to that?
No, that's all well said. You can see, I guess I do. You can see how the smooth shank of a designed screw that is only partially threaded, by necessity, by the way the engineers designed it, the near cortex won't have any fixation. It'll just be smooth gliding. But the only way we have in order to create that when you're using a fully threaded is to overbore it. So like Jeremy said, the threads just can't grab it because the hole's too big on that near cortex.
and I think Mark brought up this question last week, as in these partially threaded screws come with different amount of threads. And so by doing a lag by technique, you can drill up into that fracture site and then therefore allow as much threads past the fracture site as you need. With the partially threaded, you're only you're committed to how many threads. So say the fracture was here, right? If you have any threads crossing over that fracture site, they're going to engage the bone on the near side of the fracture site, and this won't allow for compression. If you're doing it by lag by technique, you can drill all the way up to this area, and then therefore you only have threads engaging the cortex or the bone past the fracture site. Alrighty, and then this is the last question. Again, this one's a little bit technical. Let's see. So when you're dealing with compression plating, what's the order of your screws going to be? So is your first screw concentric or is it eccentric? And if it's eccentric, should you put it near the fracture site or away from the fracture site?
And the centricity, Jeremy, that you're talking about there, you're referring to the centricity within the hole, right? Within the hole of the plate.
Correct. And then it's the same question for screw number 2. So when you're doing this, remember the first screw is anchoring it, and then the second screw is doing the work of the compression. Alrighty, we're up to 70% voted, so let's see. Alrighty, so yeah, it looks like the majority of you guys got this one correct. So if we look at this again, so the first screw is always going to be concentric. It's going to be in the center of the hole. And if you remember, the way the screw holes are oriented, if you're looking at them from the side, there's a obliquity of the screws where there's an incline. So if you drill it concentrically, the screw, once you start threading in the screw, it's going to just concentrically go to the center of the hole. The second one, you're going to drill eccentrically, and you're going to put it on the far away from the fracture site. So if the fracture site's to the right here, you're going to drill it eccentrically to the left. And as you tighten down this screw and it engages the plate, it's going to hit that incline. And the screw isn't going to go anywhere because it's already threaded into the drill holes of the bone. But it's going to push the plate as well as the bone that's already anchored here on the right side towards the left. And it's going to allow for compression at that fracture site. So again, it's the first screw is concentric, meaning it's right in the middle of the hole. And then the second one is going to be eccentric away from the fracture site. And I didn't mention this last week, but the way you place these eccentric screws are with drill guides, and there's a couple different ways. The most common one now, I think, is this spring-loaded guide, where there's a spring inside this guide, and if you push it down, it's gonna this little area here is gonna retract, and it's gonna allow you to seat your guide right in the middle of the hole. So if you push it all the way down, it's going to give you a concentric screw. If you relax and you just move your guide exactly where you want it, you can then put it up to the edge of the plate, and this allows you for an eccentric screw. So you would first do concentric and push it down deep into the drill hole. And then the second time, to get an eccentric screw, you would do just light touch and let it just touch the side of the plate. Another way is Synthes has this green gold guide where one side is for concentric screws and then the other side is for eccentric screw.
So before we move on, there were two questions in the chat from Yazan and from Kirk. I think they're kind of asking the same thing. Yazan asked, how much clearance do you leave for lag by technique? And Kirk asked, how do you determine the depth to drill? So when you are doing a lag by technique and you are trying to over drill the near cortex. So it's kind of two situations. In the first situation, if you're doing this in diaphyseal bone, meaning it's basically one hard cortex, then an open hollow tube, then another hard cortex, you're just going to pop the first cortex with the larger drill, and that's it. And then you drill the far cortex with the small drill. However, if you are in metaphyseal bone, you're not going to have that hollow tube in the middle. So there's bone all around you, and you do have to drill right up to the fracture site. And typically we do that using fluoroscopy. We can see where the fracture is on x-ray, and then using fluoro, we can guide the drill bit up to, but not beyond the fracture. If you are using a lag by design screw, you have to use some amount of imagination and extrapolation of what you can see on the x-ray. There maybe is already an implant on the x-ray that you know the size of. Let's say you've already put a 4 or 5 screw in, so therefore you know what 4.5 millimeters looks like. And then you can look and see how much bone you have on the far side of the fracture. And then you say, okay, it looks like there's about 10 millimeters on the far side of the fracture. So then you might select a screw that has less than 10 millimeters of thread count, so that those threads only engage the far side. Does that answer the question? Cool.
Alrighty. Any questions about compressing through a plate and about the technique for that before we go on? All right. And then I'm not going to go through this again, but most of the time we're doing it for a transverse fracture, but you can do it for an oblique fracture. You just have to orient your plate in a correct fashion where you can create an axilla to trap that piece of bone so it doesn't go anywhere. So your first screw, you're going to place on the obtuse side. So if the fracture is here, this is the obtuse side, this is the acute side. So your first screw is going to be your concentric screw on the obtuse side, and then your second screw is going to be eccentric, and it forms this axilla where the bone can be compressed to. If you do the opposite way, you're going to create shear. And then lastly, we got our bonus question here. Ippolito felt very strongly about his answer.
I didn't know all these options. Both of you are wrong, Jeremy. It's very obvious. I can't believe either of you.
So I'm liking the results so far. Oh, my choice is ahead so far.
No way.
Here we go.
I'm going to lead this lecture.
Keep them coming. Keep them coming. All right, I'm ahead, so I'm going to stop it. All right, so I think Remember the Titans is the best, with probably a close second, maybe Miracle. Joe Ippolito was very strongly against Rudy.
Yeah, it's obviously Rocky.
So Rocky's great. I know, tough question.
All right, so everybody who answered anything other than Rocky, you can leave. Everyone else who answered Rocky can stay for the lecture.
All righty. So I'm going to stop sharing this. Oh, Dr. Leggett, how are you doing?
Doing well, Dr. Hreha.
Andrew Leggett's one of our interns as well.
Can some people would people be willing to enter into the chat kind of what year they are? Just maybe I can see how to tailor this lecture a little bit. It's a little bit difficult. I know that we have some of our interns, we have some of our incoming interns, assuming some 4s and 3s. 4s, 3s, there's 1, 1, 3, 4, a 3.5, nice. 3s and 4. Okay. All right, so for the medical student 1, if you're ahead of everybody else in your class, great. If any of this is going either too fast or too slow, Jeremy can kind of referee me in. I didn't have a lot of chance to really rehearse this. I spent a good bit of time putting it together, but if I'm sort of glossing over things or taking a few things for granted, hopefully Jeremy will kind of rein me in. I'm hoping to go into trauma. This is a subject matter that's very interesting to me that I enjoy a lot, so hopefully we should have a good time. Everybody see that in presentation mode?
Yep, all good.
Okay, so in this lecture, a brief outline, we'd like to go over an introduction to intramedullary nailing. We'll be focusing on some of the basic principles, some of the mechanics of nails and how they lead to healing. We'll go into some of the technical aspects of it so that you guys can have some understanding of what's going on when you go in cases. And then we'll go through a couple of cases just to sort of bring it home. So my objectives, what I hope for you guys to take from this, I want you to understand and I want you to feel comfortable with the nomenclature that we use around intramedullary nailing. For instance, what's the difference between a hip nail and a reconstruction nail? Brands tend to cause confusion. That will come with time, so I don't want you guys to try to focus on that. I want you to be able to describe the use of an intramedullary nail and understand what indications are in the wheelhouse of a nail and where are the stretched indications and what we sort of term extreme nailing, where it's really coming to some technical extremes. We'll go through a little bit of a reviewing of fracture morphology and types of fractures. And we're going to describe the goal of reduction, the mechanics of stability provided by a nail, and I want you to be able to describe the type of healing and what you would expect to see when you're following these patients. And then finally, you should be able to recognize the key steps and build your foundation for understanding what you're seeing in the operating room. So briefly, let's talk about the anatomy of a nail so that you guys sort of hear, when you're hearing us talking about things, you know what we're talking about. So the nail itself, we can see, can you guys see my pointer?
Yep.
Okay, so we have the nail look from a frontal profile and from the side profile. This is a tibial nail, just as an example. You can see that there are lots of intricacies of the nail. There are multiple holes down at the distal end. There are holes in the proximal end. There's a chamfer cut at the top. There's this big bend in the middle. On tibial nails, this bend is about 1/3 of the distance down, and that's called the Herzog bend. It has a very specific purpose, which we can talk about. There's this piece called the insertion handle, which this isn't actually the best picture. There will be another one on the next slide. This is actually the targeting jig, which attaches to the insertion handle. And that targeting jig allows you to precisely put interlocking screws through these holes up near the proximal end where you're inserting it. There's a starting point guide wire, which looks very similar to a K wire. It's just a sharp pointed wire that we use under fluoroscopy in order to obtain our perfect start point. There's an opening rigid reamer that once we've obtained our start point, we bore a hole into the top of the bone. The beaded tip guide wire. This is the rigid reamer right here. I forgot that I included some of these pictures. And along with the rigid reamer, there's a soft tissue protector. This slides in through the incision that we've made so that as you're spinning this aggressive reamer, you're not destroying the remainder of the knee joint, for instance, or destroying the gluteal muscles around the hip. After we've placed our beaded tip guide wire, which you can see down here going all the way down the bone, then we use a flexible reamer, which can flex to the different contours within the bone and expand the medullary canal. Here you can see a better depiction of the insertion handle. It's a rigid metal arm, which usually has an attachment jig that we can put on it in order to mallet the nail in. There is a triple sleeve guide, which I don't have a good picture of, but you'll see one in some of the other pictures, that slips through these holes of the targeting jig, and it acts as an arm that guides the drill bit down, shows you exactly where you need to make your cut in the skin, and then can guide the drill bit in so that it slides perfectly through these holes. There are static and dynamic holes. All that means, a static hole is a circular hole. A dynamic hole is an oblong hole. And you can see if you put a screw through an oblong hole, there could be some motion at that segment. We can talk later about how you can actually put a static screw through an oblong hole, but you could never put a dynamic screw through a static hole. There are all sorts of bends and kicks. We talked about in a tibial nail, about a third way down. This is called the Herzog bend. Most tibial nails also have a little bit of a flare at the end of it, which is designed to help slide the nail in, almost like a shoehorn. It also has some implications for how you might be reducing the fracture. And then this chamfer up at the top is in order to provide more clearance to prevent it from sticking out into the knee joint. And there are similar bends on a femoral nail or on what we call a hip nail that are designed for specific purposes. And then, of course, there are the interlock screws. Sometimes you may hear those called crosslock bolts. They are a little bit different from typical screws that we put in for plating. These are larger diameter screws that have very good axial load and stiffness parameters that allow very high bending strength. They don't have very big threads that bite the bone very well, but they do have very good bending strength. And so here is a modern generation nail. This is Synthy's latest nail. And you can see that these nails have come a long way to the point where we can put in screws in all sorts of different angles and at different levels, different heights, depending upon where the fracture is or what type of stability we need to give to the fracture. A little bit more about the nomenclature. So a cephalomedullary nail, this describes a nail that fixes both the medullary canal and the head of the femur. In other words, this is a nail that we would use for a hip fracture. It has this crossing bar or screw or a bolt that goes up into the head, and it can be used for intertrochanteric fractures here or for femoral neck fractures. Sometimes it can be used for subtrochanteric fractures, and it can also be used for femoral shaft fractures. Some of us have biases as to why we might not want to use it for the last two. I'm happy to answer as many questions about that as you guys want. This is sometimes colloquially called a hip nail. It also is a form of a trochanteric nail. A trochanteric nail doesn't refer to the specific implant. It refers to where the implant is put in. So for nails that enter the femur, there's commonly either one that enters through the greater trochanter, or one that enters through the piriformis, which is a little bit more medial. And this is a typical piriformis nail. You can note that there are a couple of things that are different about this. This nail is very straight as opposed to having the slight bend at the top that a trochanteric nail has. Also at the top, it's the same diameter all the way down. The nail is not getting any larger, whereas these trochanteric nails, the hip nails, have a much larger body up in the metaphysis of the bone. And that's in order to allow this large crosslock bolt in order to go in. For nails that we use on the femoral shaft, we can put them in forwards or backwards. We call that antigrade or retrograde. And some manufacturers make them where it's literally the exact same nail. You can just drill a hole from the top or from the bottom. And there are reasons we might do one or the other, which we can go over towards the end. Something called a reconstruction nail, if you guys ever hear that, sometimes we call it a recon nail. All that means is that the nail has these oblique holes in it, which allow us to put screws up into the femoral neck. You could have a recon piriformis start nail. So this particular one, I don't know whether it has those oblique holes or not, but the ability to put those oblique screws is what makes it a recon nail. And then you can have short nails and long nails. Short nails typically stop at about 170 millimeters, just about 5 to 7 centimeters below the lesser trochanter. And those would typically be used for little old ladies who fall and have a hip fracture. Those wouldn't be used if you had a fracture in the midshaft because the nail can't even go far enough down to fix that. These are the things that I don't want you guys to get caught up in. Gamma nail, T2, T2 alpha, TFN. These are all just brand names. And the more you get into this, it's good to learn, and it's critical that you understand what your implant is and where the specific holes are. This is not the goal of this lecture. So a little bit about the applications and use. Nails are most commonly used for long bone fractures and are very right in the wheelhouse is for diaphyseal fractures. So these fractures right in the middle of these long bones, you can use them in femurs, tibias. There are humerus nails, and there are even nails for the ulna and for the fibula. We're not going to really spend any time talking about the last three. Happy to answer questions if you guys want to, but we'll focus on the femur and the tibia. In addition to mid-diaphyseal fractures, these can be used for metaphyseal extra-articular fractures. That would include femoral neck fractures. That is a type of metaphyseal fracture of the femur, an intertrochanteric femur fracture. And it can be used for a select intra-articular fractures, but we're not going to talk about that today. That requires some specific uses. I want you to separate these in your head. Okay, femoral neck fractures, intertrochanteric fractures, those are hip fractures. The way we treat these is different than the way we treat diaphyseal fractures, and it's also different than the way we treat the other type of metaphyseal fractures. Subtrochanteric femur fractures have very specific things that make them difficult. Distal femur fractures have very similar attributes to proximal and distal third tibia fractures that make it difficult to treat. These are just a separate entity entirely. So let's talk about the types of fractures. You can use nails to treat simple fractures, no matter what morphology it is. You can use them for wedge fractures or bending fractures, whether there's comminution or not. You can treat segmental injuries, whether they're complex spirals or comminuted fractures. All of these are amenable to nails. So how does a nail actually work? Well, it's helpful to think of it in your mind as an internal splint. Kind of the same way a cast works like an exoskeleton, it holds the overall alignment. It doesn't specifically control what happens in the middle. It just lines everything up and holds it there. And it works by two mechanisms through a 3-point bending model, where the forces are being applied to the bone in multiple areas as gravity is affecting the bone. And this nail is impacting the endosteal cortex here, and the screws are holding it here and here so that it resists 3-point bending. It's also a load sharing device in that when a patient walks, for instance, the two ends of the bone here share some of the weight of the patient as they walk. All of the weight is not being requisitely placed on the nail. It maintains length, alignment, and rotation, and we don't really care what happens in between. So some review of the principles of fracture fixation. We want to restore, we want to reduce a fracture in order to restore anatomic relationships. We want to provide enough stability dependent upon the personality of the fracture, okay? And that goes back to what Jeremy was talking about earlier about for simple fracture lines, we like to compress them and give them very rigid fixation. And for comminuted fractures, we like to give them a bridging construct in order to allow some motion. So you give it as much stability as the personality of the fracture requires. You want to preserve blood supply and soft tissues, and then you want to restore the patient's function as soon as possible. So how does a nail help us achieve those goals? So for our reduction, the goal is to have a functional alignment through restoration of anatomic relationships of critical structures. We are not going for a anatomic reduction here. We don't care if every single piece of the bone is perfectly aligned and fit back together like a jigsaw puzzle. What we care about is that the mechanical axes, in other words, the axis of this neck and where forces are transmitted to the head, we care that that relationship is appropriate to the relationship of the distal joint, okay? We wouldn't want this to be kicked in, say, an oblique fashion like this. We want it to be correctly aligned relative to the neck. We care about the joint alignment, the myotendinous units, and the neurovascular structures. Obviously, if you turned the bone around 180 degrees and twisted up the sciatic nerve, that's not achieving your goal. So again, none of this in the middle matters as long as the relationship here is appropriate to the relationship here. Stability, what sort of stability are we going for here? These nails typically are used in a relative stability fashion, not an absolute. It means there's no interfragmentary compression. We are not compressing these fractures. We are not going for direct bone healing. That does not mean weak or unstable, so don't confuse that in your mind. We can have patients walk on femoral or tibial nails, but almost never would we let patients immediately walk on a plate. So just because a plate is absolute stability, unless it's a bridge plate, nails are typically relative stability, and we let patients walk on them all the time. The reason that it's incredibly strong is because of where a nail acts on the bone. It's right down the center of the medullary axis, which means that where forces are transmitted on the bone, let's use a femur as an example, forces are transmitted from the head in a direct line straight through the middle of the knee joint. And the distance from where the force is applied to where the nail is located is much shorter of a distance than the distance from that force to where a plate would be applied. So a nail has a distinct mechanical advantage over a plate. Also, nails have a larger cross-sectional area over a plate, which means it has a much higher bending stiffness. And finally, nails are load-sharing devices, meaning the friction of the internal bone cortex rubbing against this nail allows force transfer from the nail to the bone all the way along the length of it. So you're not entirely relying, like a plate, where you're relying on the strength of the plate. Some of the forces are shared by the bone in a nail. And we can talk about how the cross-lock bolts in a nail are much larger than the screws typically used in plates. And as the radius of a cylinder increases, the strength goes up by a power of the fourth. So for instance, a 5mm cross-lock bolt is far stronger than a 4mm screw.
Sorry to interrupt you. And so the diameter of the screw also is the R to the fourth. So the larger you go up with, the diameter of the intramedullary nail is also stiffness increases by R to the fourth. So if you go up in size of the nail, you're going to increase stiffness as well.
Absolutely. And that kind of comes back to the reason that we ream the medullary canal. There is a lot of stuff in the literature about using reamed or unreamed nails. If you don't ream the inside of the medullary canal, you can't fit as large of a nail. So by reaming it up, we're able to put a stiffer nail in.
Sorry to interrupt you one more time.
Sure.
We just got a question of why do we avoid compression with these nails?
Excellent question. So if you think about, I wonder if there's a good illustration I can use. Okay, so let's look at this fracture right here. This is a relatively simple fracture pattern. You can imagine a situation where you could compress this back together. You could maybe put a lag screw here, a lag screw across here, and you could compress this fracture line really nicely and get a direct bone healing, an absolute stability, primary bone healing with no callus. However, in order to do that, you're going to have to remove a lot of the muscular attachments in order to get down to that level. So there's going to be a lot of stripping. In order to compress this fracture, you would have to violate a lot of the biology in order to do that. And a nail is a very biologically friendly device. I'll show you in the next slide. I think I have something demonstrating that where you're instrumenting, where you're cutting this patient is all up here. For a hip, for instance, or for a femoral shaft, you're cutting the skin above the trochanter. You're putting a soft tissue protector down through here, through the gluteus, and then you're drilling a hole in the bone here. You're never going anywhere near this fracture. All of the muscular attachments here are preserved, and the only damage to the muscles here is the damage that was already done by the fracture. And then you're putting in cross-lock bolts down here. So you're going for a different goal. Whereas this type of fracture may be amenable to compression and getting that type of healing, you don't need that with a nail. You can just go for a secondary intention, and by restoring the relationship of the femoral head and the alignment of the neck to the femoral condyles and the rotation, whatever happens in the middle doesn't matter. It's going to heal like gangbusters. I think, Jeremy, is there anything you want to add to that?
No, that was nice.
So kind of stepping on the toes here of healing. So the type of healing we're going here is for secondary bone healing. There's going to be robust callus that you would expect to see on follow-up radiographs of either a tibial nail or especially a femoral nail, because there's so much soft tissue, so much muscle, so much good vascularity that surrounds a femur. You would expect to see a lot of callus healing on this. So that requires interfragmentary motion, and it requires that you have a little bit of strain in between the fracture sites, which goes back to why we don't compress these. And again, these are extremely biologically friendly devices. We never have to touch the blood vessels that live anywhere around that fracture site. So we're not going for cutting cones. We're not going for compression. We're going for callus. Okay, and you can see here the fracture, as you have a good alignment. It doesn't look real sexy in here, but just eliminate that from your mind. The relationship of the joint surface here is appropriate to the relationship of the joint surface here. And here we have callus, 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 and even callus on the fibula as well. And here on the lateral, you can really appreciate how much callus formed here. So going back to callus formation, how do fractures heal? Initially, you have an inflammation. This is from last week's lecture. You have a hematoma formation that brings in a bunch of, we'll call them good juju stuff. Then you have soft callus formation, where you have soft bone or a cartilaginous onlog that's laid down. And then you have increase in the vascularity and vessel ingrowth at that time, bringing fibroblasts that lay down fiber across it. And as the fiber stiffens the site, the strain in this environment is decreasing. And you have to think about this as an evolution that happens. Initially, there's a lot of motion and a lot of strain. Fibroblasts lay down collagen across it. It decreases the motion, decreases the strain. Then you can have cartilage laid down across it. It gets even stiffer, decreased strain. Then you can have osteocytes that start to build across it, forming the hard callus. It's important to know that the osteocytes are not replacing, they're not converting the soft callus into hard callus. They're actually replacing it. Okay, and then over time, over the next 18 months, you have remodeling and laying down of these new lamellae, these new Haversian canal systems. So let's go into a little bit of the techniques. So any intramedullary nailing is going to be done under general anesthesia. You want the patient to have muscular paralysis so they're not fighting you. And this is almost always going to be done with at least one assistant. In academic centers, anywhere you guys are going to be, there's probably going to be one resident and one student, or two residents and a student in these cases, because there's a lot of work that goes into them. For hip type fractures, these might be done on, this is what we call a fracture table, where the patient is suspended with only support under the gluteus, and the legs are free floating in these holsters. And you put the well leg out of the way. You bring the C-arm in between the two legs in order to be able to image the injured leg. And this outrigger boom can apply traction to the injured leg, and you can change the rotation as well, so that you can work up here and instrument the femur. Typically for a femoral shaft or for a tibia, we're going to do this on what we call a flat top. There are a lot of devices, a lot of manufacturers. You may hear residents call this an OSI. You may hear us call it a Jackson. You may just hear us call it a flat top. All refers to the same thing. You can see how this table is all radiolucent. You could put a C-arm anywhere underneath it, and you can see anything you need to see. Typically, we bring in the fluoroscopy from the contralateral side. So a little about the reduction. This is critical, okay? The nail does not reduce the fracture for you, okay? There are times when a nail may help you, but that should never be your goal. The nail maintains the reduction after you have obtained it. You're going to be doing a reduction predominantly by fluoroscopic technique. You're going to be looking at the fragments under radiographs and aligning them in a variety of ways. You can make small cuts near the fracture. I know we talked about it being biologically friendly, but you have to do what you have to do to line the fracture back up appropriately and reduce it. So sometimes you might make tiny cuts and put a clamp on. Sometimes you could put little joysticks in to manipulate it. Sometimes you may see us even put a small plate on it. And this again is a very limited incision. We're not doing much damage to the skin here, to the muscle here, as much as we would if we had to put a full-sized plate on it. And sometimes we may either have what's called a femoral distractor or a universal distractor on, or we may put an external fixator on. Those would serve a very similar purpose. And you could sort of manipulate that and titrate it in and get the alignment and then lock it in and then do all of your intramedullary instrumentation. So remember we talked about the way a nail works is by 3-point bending. 2 of the points of those 3 points are the start point and the end point. So those are very critical. Okay, so getting your start point is, one of our mentors says it's the whole case. You get the start point, the case is done. If you mess the start point up, you're going to struggle for the remainder of the case. So in a tibia, the correct start point is just above the angle from the articular surface to the anterior chamfer and slope of the tibia. And it's going to be in line with the center of the medullary canal, which happens to be just on the medial slope of the lateral tibial spine. So if we look down on it, you're going to see it right here. For what we call a piriformis entry nail of the femur, this is going to be located just in line with the medullary canal of the femoral shaft. It's not in the ideal location for fixation into the neck. As you note, it's posteriorly located relative to the neck of the femur, but it's perfectly in line with the femoral shaft, and it's just a little bit medial to the tip of the greater trochanter. For a trochanteric entry nail, this is going to be on the tip of that greater trochanter, and it's about at the division of the posterior 2/3 of the trochanter and the anterior 1/3 of the trochanter is about the spot that you want to put that in. What about if we're going backwards in the femur? If we're going to do a retrograde, we might go just medial to the tendon, the patellar tendon, dissect down through Hoffman's fat pad, and then find the perfect start point on the distal femur, right in the trochlear groove, about 1 centimeter above the insertion of the PCL. And it's going to be just a hair medial to the deepest part of the groove. On a radiograph, you can see that that corresponds just at the tip of Blumenstadt's line. Blumenstadt's line is this radio-dense line here. If any of you guys have seen total knee arthroplasty, we talk about that line all the time.
Can I add something real quick?
Yep.
So the starting point also depends very highly on getting correct radiographs. You have to get a perfect AP and a perfect lateral of the area that you're getting, or your starting point is going to be off. Joe, do you mind just describing about perfect lateral, the knee, and how that would throw us off?
Yeah, sure. So I have some good pictures of that a little bit later. I don't want to skip ahead and sort of spoil anything, but there are well described parameters that you want to look at for each area of the body that you're looking at, trying to obtain a perfect x-ray. For a lot of the stuff that we're doing for nailing, we're always focused on the knee, and we're focused on getting perfect x-rays at the knee. And the easiest and most consistent x-ray that you can get at the knee is a perfect lateral. A perfect lateral at the knee is one, this is not a perfect lateral, but it is close, it's pretty good. One in which the posterior convexity of the femoral condyles should overlap. So here you can see here's one condyle shadow and here's another, and they're off by a little bit. What that means is that if can you guys see my hand? I don't know, you're all focused on that, never mind. If you imagine this leg is horizontal in space and the C-arm is in line with your eyes right now, so you're looking through the knee. If you were to rotate that knee, internal or external, you can imagine how these posterior condylar shadows would change relative to one another. And so the problem that they have with this one is their rotation of the femur is off by a little bit. Also, there's something we call either wig-wag, or we call it the adduction or the abduction of the leg, abduction or adduction. And if you are off in that plane, what you'll see is the distal femoral shadows will not overlap correctly. Now, a caveat to that is you are never going to get the posterior condylar shadows to line up perfectly as well as the distal shadows, but there should be a most congruent image. We know that the medial distal femoral condyle projects more distally than the lateral femoral condyle, so it should always project a little bit farther. So you're never trying to line up the distal just perfectly, but you want it to look congruent relative to these. On an AP, there are a number of things that we look at. You want the patella to be centered within the femur, so you can look at the shadow of the patella. If the patella looks like it's too far lateral, you know your leg is externally rotated. If it looks like it's too far medially, you know you are internally rotated. And then you can look at the tibia as well, and you can look at the relative location of the fibular head. The fibular head should overlap the tibia by about 1/3 of its distance, and if 1/3 to 1/2. And if you see the entire fibular head hanging out in space, you know that you are too internally rotated. Or if you see the entire fibular head behind the tibia, you're too externally rotated. And there are a couple other things we can talk about, like at the ankle, and then other things we look at the hip. Okay, so that was for our entry point. So let's use the tibia as the example. After we've obtained our entry point, we would use our opening reamer to gain access to the medullary canal. Okay, and we use a soft tissue protector in order to protect the patellar tendon, in order to protect the articular cartilage there. And then we would introduce the ball tip guide wire. And again, you can see that here in this illustration, the fracture is being reduced first, and then the guide wire is advanced past it. And there are some neat tricks that you can do in order to make sure that your ending point of your nail is correct. Commonly, we will put a small bend in the guide wire. This is actually a very weird guide wire. I've never seen one like this. I don't know if Jeremy has, but the principle is the same. By using a bend in it, you can twist the T-handle chuck that you're using to control the guide wire. And by twisting it and seeing where that relative bend is on fluoroscopy, you can then advance it farther and twist and farther, and you can make sure that you end dead center on the lateral and dead center on the AP. And then there are some advanced tricks as to whether you might want to modify that location based on what you understand about the fracture. But in general, we aim for dead center.
Yeah, I was just going to point out that that guide wire is too much of an acuity of a bend. You want just a slight bend to just help you facilitate which direction you're rotating your guide wire to get that perfect placement. But if you have too big of a bend, like in this case, once you insert your nail over your guide wire, you're going to have a hard time getting that guide wire out because the angle of the bend is too big to fit through the inner diameter of the nail.
I will say that there are a lot of different ways of doing this, and even at our institution, our attendings all put different bends on this wire. But Jeremy is right in that if you bend it too much, you can imagine trying to bend an angular trying to pull an angular structure out through a straight tube. It's not going to work very well.
Also, Joe, it's 8 o'clock now.
Oh boy.
The call, I think, is still 8:30, but
Okay.
just to speed things along.
All right. So got a couple of cases to go through. So let's see. It's just illustrating the flexibility of the reamers. We have a variety of tips that we can use on these. The only thing I want to point out to you guys is that some of these reamers are sharp on the end and they can cut their way down through bone. We call those end cutting reamers. And then sometimes after you've passed the first one, you don't need to keep cutting the bone away in front of you. So you might use one that only has cutting flutes on the side of it. This I put in to remind me to talk to you guys. One of the downsides of nailing, or the things that you need to be aware of, is a medullary embolus. So it is possible when you're reaming a long bone that because of the pressure of shoving a stiff metal rod down the center of that canal, that you may displace some of the marrow, and that can seep into the bloodstream, especially through ruptured blood vessels that live around the fracture, and then cause an embolus to the lungs. Okay, so that can be minimized by your technique by be very slow in advancing the reamer, as well as it's lessened by the fact that the pressure within the canal is decreased by the fracture. Probably a waste of time to talk about that. Okay, this is just illustrating how the disc proximal targeting jig sets us up perfectly to put our triple sleeve guide in and place our proximal interlock bolts. But the fun part starts when we try to lock up the distal part of the nail, either for a femur or a tibia. We have to use what we call perfect circles. Here's a jig looking at a femoral nail. This would be for a cephalomedullary type device to fix the head of the femur. In order to put bolts in the distal part of the nail, you have to first start off by getting a perfect radiograph that's looking straight through the distal interlock hole. And you can tell when it's off because a perfect circle will not be perfect. It will be a oval. And you have to change your fluoro in order to get a perfect x-ray. Then after you've made an incision and you're ready to place your drill bit, you place the center tip of the drill bit in the center of the hole from an oblique angle to keep your hand out of the way of the radiograph. Once you know that the tip of your drill bit is in the perfect center of that hole, you can then put your hand in line and then drill your drill bit across that hole. Then you have to remember your angle and put your screw in. Just a little bit about antigrade versus retrograde nailing for femoral shafts. The indications that you can use these for are all the same, but there are different advantages of using one versus the other. So most of the advantages of an antigrade nail are also retained by a retrograde nail. However, with a antigrade nail, you do not have to violate the knee joint. You're all going through a muscular compartment and you're never going through a joint. So these are all just some of the advantages of any nail. Talk about that later. Looking at a retrograde nail, some of the times you may see us use this are when you have bilateral lower extremity fractures. If you have double femoral shaft fractures, it may be easier to just nail both of them from the same position because you don't have to shift the patient from one side of the table to the other in order to gain access to the hip. Or you can just go straight from the knee in both of them. If you have a concurrent acetabular fracture, you may want to instrument the femur from farther away. Or if you have an ipsilateral femoral neck fracture, sometimes we may use a specific implant in order to treat femoral neck and then retrograde the femoral shaft. Also, if you have something in the way, like a hip prosthesis, if the patient has a hip replacement, you obviously can nail from the top down.
Also, Joe has it listed there. In polytraumatic patients, you might want to do retrograde because just the positioning of the patient may be beneficial to fix other bones at the same time.
So let's go through some cases. We have a 31-year-old female here. She's status post MVC. She was a restrained driver. And, oh, she just happens to be 8 months pregnant. So here are the radiographs we obtain in the trauma bay. It's very common that we get these multiple views of femoral shafts. That bone is too large to capture on one x-ray. So we'll usually have an oblique x-ray, not an AP or lateral. It's just some odd view of the femur, and then another odd view, and then usually we can get AP views. So here, if I were to describe this fracture.
Before you do, let's have Tej give a shot.
Oh, Tej is going to give it a shot.
Oh yeah.
Can you unmute yourself,
yeah.
Tej?
So you have a AP and lateral of the left femur.
You can exclude anybody. Doesn't have to say AP and lateral. That's okay. We'll just assume that you know that it's an AP and lateral.
With a transverse midshaft femur fracture, posteriorly displaced and medially displaced.
It's actually a little bit laterally displaced. Very confusing given the fact that you're looking at multiple views, but I think this view here is the one that kind of gives it away to you.
It's posteriorly and laterally displaced. Simple.
Good. Excellent. And additionally, in addition to the displacement of translation, it's translated posteriorly and it's translated laterally. You could also talk about the angulation. So you have sort of a posteriorly angulated fracture, or the distal fragment is angled anterior. Does that make sense?
Mm-hmm.
So if you kind of look at the kick, the line here, and that's caused by the pull of the quadriceps pulling this up, and then some other muscular forces, the iliopsoas is pulling this shorter fragment up as well. Okay, so what might we want to do? What do we want to take into account? I would highlight the fact that she's 8 months pregnant. Okay, so if we could nail this fracture either antigrade or we could nail it retrograde. If we're to nail it antigrade, we're going to be really focused right here the whole time. She's got this big fat belly in our way with a big old baby in there. And then we're trying to be conscious of the baby. So if we're very focused on obtaining our start point here, we would be taking a bunch of x-rays right around the baby. So I would submit to you that a better way of doing this would be a retrograde nail, so that the majority of our x-rays would be done around the knee. It's not a hard indication, but there's a lot of pros to that. So that's what we did.
Similar to obese patients as well, you may try to do a retrograde for the same reason, because of the
not because you're trying to spare her fat, the x-rays, but because it is hard to work around the hip on obese patients. So here we start off by obtaining a perfect view of both the knee and the hip of the contralateral side. The reason we do that is, remember, we don't care what's in the middle. We care about the relationship of the hip to the relationship of the knee. And part of that relationship is rotation. It's a very important part of it, okay? So we obtain a perfect x-ray of the knee. Here you can see those posterior condylar shadows are dead on. And you can see that when we get that dead on, the medial femoral condyle projects a little bit farther distally than the lateral femoral condyle. This is a perfect x-ray of the knee, okay? And this is only one technique. I will tell you, this is only one technique of obtaining rotation, but this is the way that we do it. And there is evidence that this is the best way of doing it. After you obtain a perfect x-ray of the knee, you roll the fluoroscopy C-arm up 90 degrees. No one moves anything, and you slide straight proximal up to the hip. And you take an x-ray of the hip. There you focus all of your intensity, all of your eyeballs. You focus on the profile of the lesser trochanter. How much of that lesser trochanter is peeking out from behind the femur, okay? Then we turn our attention to the injured side. We're going to obtain our x-rays. We're going to obtain a perfect start point right at the tip of Blumenstedt's line, right in this depth of the concavity of the trochlear groove. We've reduced our fracture right before we slide our guide wire across it, and we're going to advance it up to the place where we want it to end. Now here we see our flexible reamer. We've reamed all the way up to the top. Don't make the mistake of stopping your reamer short. and not being able to finish inserting your nail because you didn't ream out the top. Then as we insert our nail, you can see this is a special type of fracture. This is a fracture right in the narrowest part of the bone. So this nail does help us with reducing the fracture, but I want to make sure you guys understand the job of the nail is not to reduce the fracture. The job of the nail is to hold the reduction. Okay, and then after that, we're going to obtain a perfect x-ray of the knee before we lock our nail up. Okay, we obtain a perfect x-ray of the knee. We roll up 90 degrees. We take an x-ray of the hip, and we look at that profile of the lesser trochanter, and we make sure that it looks the same. If there's too much lesser trochanter poking out, that means that our rotation is off. And what it actually means is that we're too internally rotated distally. And if there's no lesser trochanter poking out, it means we're too externally rotated distally. Okay, after we're satisfied with our profile there and that we have our rotation correct, we can lock it up. And this would be done with a perfect circle technique proximally. Okay, so here I've put up our injured side next to our good side. And you can see, I think that these profiles look pretty close. If I'm being hypercritical, maybe a little bit less of the lesser trochanter is visible here compared to here, but pretty good. Here are her post-op x-rays, nice alignment. Here she is at 6 weeks post-op, just 6 weeks, that's it. And already you can see how much callus she's forming around this. So even though this is a simple fracture line, one that if we were plating, we would typically want to compress it and get no callus, we're completely violating all of those principles with a nail, and we're going to relative stability for a simple fracture line, and still she forms robust callus because there's just so much good blood vessels and vascularity here.
Hey Joe, I often hear in the operating room the word chatter. Can you explain what chatter means in reaming?
Sure. Look at the heads of these reamers. What you see are these cutting channels or flutes, and the flute is the recession within the head, and on each side of the flute is a blade. There's a blade, there's a blade. And as that spinning blade is advancing through the shaft, let's look here for a opposite example. There is a ton of space in the proximal femur metaphysis. Those cutting edges and the flutes are not contacting anything other than soft metaphyseal bone. You won't hear anything here. But look, no, I thought I had a picture, but I don't. Okay, let's imagine at this point right here with the beaded tip guide wire, if that was the reamer, the edges and the sharp cutting edges of this reamer would be knocking back and forth off of the inner cortex of this bone. And you can both hear and feel that as the reamer is advancing through there. That's what we call chatter. So if we were to measure this canal and say that it's perhaps 10 millimeters in diameter, if you passed a 9 millimeter reamer through it, you would not expect to hear chatter or feel it. But once you put a 10 millimeter and especially a 10.5 millimeter reamer, you would really feel and hear chatter there. And that's one of the most important feedbacks that we use to gauge, are we done reaming? Should we go for a little more? Maybe we haven't reamed up enough. There was no chatter there. We could probably fit something bigger through this. One important technique to that, especially for our incoming interns and for our current interns, is that if you are experiencing chatter, you do not stop the reamer, ever. If you stop a reamer at the point where you are hearing and feeling chatter, that means that that reamer head is tightly engaged here. And if you stop, it may embed itself. And then when you start to turn it again, it may bind. And the new drills that we have, we use a Striker 8. They have a lot of torque, and you can actually break a femoral shaft. So if your reamer is here In the wide open metaphysis, there's no chatter whatsoever. It's perfectly safe to stop the reamer, take an x-ray, whatever you need to do. But if you're feeling chatter, don't stop. You either keep going, or if there's a problem and you can't keep going, keep spinning, but back up a little bit. So here we have another example. We have a 32-year-old male, status post MVC, and he has a history of some type of a hip surgery. We don't really know what he had done. We can see on his x-rays, he's got some arthritis up here, he's got some bony overgrowth, and he's got these 2 screws in. So again, this is another example. Can we go antigrade? Sure, we could. We'd have to take these screws out. We'd have to chisel away little bits of bone in order to get the right start point. But why? We can just go retrograde. So that's what we did. So let's talk about a hip fracture. This is a standard, well, actually it's not standard, this is a reverse oblique, but we won't talk about that. But this is what we would call an intertrochanteric femur fracture. So here is the lesser trochanter, here is the greater trochanter, and the fracture line is between those. Sometimes you'll see them in the other direction. And actually this direction is more common. That's a standard obliquity. This one is called a reverse obliquity. But regardless, this is a hip fracture. We're going to treat this very differently than we treated that femoral shaft. This is going to be done typically on a fracture table, that one where you have the leg suspended and it's in a holster. But you can see these fractures have a very distinct deformity, and they're commonly very far out of a reduction. You can't just nail this and hope that the nail puts it back in place. So you have to do something. Typically, here is no traction applied on a lateral view. And then once we've pulled on the leg, a lot of the reduction is done for us, but it's still not perfect. So we can go in, put a couple of clamps on, reduce the fracture. If you look at this cortical line here, you can see it lines up much better than it did over here. Then we can obtain our perfect start point. This is a hip fracture. We're typically going to do this through a trochanteric start. So we're right on the tip of the trochanter at the junction of the posterior 1/3 and the anterior 1/3 of the trochanter. You can see that here. And that alignment happens to be perfectly or almost perfectly right in the midline of the femoral neck. Here's the shaft down here. Here's the neck right here. So that is going to help us when we're trying to put a screw up into the neck. Here's a big opening reamer, because remember the body of this nail is very large, so there's a huge opening reamer to get in. And then once we seat this nail, we're looking at this opening of the nail where that crosslock bar is going to go in, or the lag bolt. And we want that to line up, and we're in our minds, we're imagining where is that going to end in the femoral head. Okay, because you want to stop at a point where you're going to put that screw right up in the center of the femoral head. So here, after we've seated it, we use our guide wire. Again, this is done with an outrigger jig like we saw earlier in order to help us guide this in. We end in the center of the head on the AP and on the lateral. Here you can see the outline of the femoral head as it coming around, and we're ending right in the center. We drill it out and we place our lag bolt. And here on the AP, we're ending in the center and we're ending in the center. Can anybody point out to me what looks off about this image? Shout it out. What about this right here? The guide wire that they placed is now in the hip joint. But they did an interesting trick, and they knew when this case was done, they knew that they had accidentally put this too far. And so in order to prevent this sharp tip from injuring the inside of that hip joint, what they did before they were done putting the screw in, they switched it out. You can see this wire is actually in backwards, and there's a blunt tip right there. So they knew they had gone through and they put a blunt tip in order to protect the inside of the hip joint as they advanced that screw in. This was my horrible job of trying to stitch the two images together to make it look like an AP, but you can see we are right down the canal and we've aligned this fracture. We don't really care as much about what's going on down here as we do when we're nailing a femoral shaft, because the mechanics of this nail are actually very different than a femoral shaft nail. We'll briefly go through a tibia and we'll be done.
Yeah, you have 10 minutes left. I think the meeting might automatically end at 8:30. So.
All right, 32-year-old male had an explosion. He has an open wound over this injury, over the anteromedial face of the tibia. Here we are. We've placed our soft tissue protector with our guide wire. We're right at our start point. This is not quite a perfect x-ray. You can see there's not enough fibular head overlap. So we're actually a little externally rotated here. If we we are a little internally rotated. If we externally rotate it a little bit, we get more fibular head overlap, and you would see that this start point was actually right on that medial slope. We've placed our ball tip guide wire right down to the center of the plafond. Here we are. We have a clamp on the fracture site. There were not as many fluoros saved for this case. I wish I could show you guys more, but there just weren't more images. But there's a clamp on this fracture site in order to reduce it before we had reamed, before we put our nail down. This is a depth gauge that we've inserted. Using a little hook on the depth gauge, we can feel the far cortex, and then we can measure how large of a nail, a cross-lock bolt or a interlock screw we have to put in. And you can note that we're putting in a lot of screws here at multiple angles. The reason we're doing that is because this fracture is up near the top. And this is an example of a metaphyseal nailing indication. This is not a mid-diaphyseal fracture. This is at the part where the bone is beginning to widen. And so the nail is not going to fill the space here. So this top part, the proximal part of the tibia, can kind of windshield wiper. If you imagine there's a nail here, it could windshield wiper back and forth on it because there's so much capacious space here. So this is getting a little bit closer to what we would call extreme nailing. This is a tougher case to do. This is a metaphyseal fracture, not a diaphyseal fracture. So in order to do that and impart more stability, we put multiple angles, multiple screws in. Here's our perfect circle for the distal part. And here's the completion. Again, this looks like crap, but who cares? The joint surface, relative to the joint surface, is correct. And what happens in between doesn't matter. It'll heal.
So Joe, I noticed in that last tibia fracture, proximally there's multiple lag screws, and distally there's just one interlock screw. And then on some of the femur x-rays, there's one distally, one proximally. Can you explain just briefly of why and when you would use multiple distally or proximally, et cetera?
Sure. So again, this is a very different indication than a femoral shaft. So in a hip fracture, all we are asking this nail to do, we are only asking the nail to keep this bolt in the relatively correct alignment to the shaft. So you have a lot of distance from here all the way through a narrow shaft all the way down. So you imagine this nail cannot tip back and forth very far because it has this long space here. So you don't need the screws to control angular motion here. All you need this screw to do is to prevent that nail from spinning in place so that the femoral neck could go into retroversion or anaversion. This screw's only job is to prevent that. With a femoral shaft, that one only had one. Oh, so this is actually great. Here we had a slightly more complex femoral shaft, not much, but you can see some comminution here, Okay, so this fracture, and even especially if we look at the tibial fracture, there's a lot of comminution here. This fracture could shorten on itself. So we need more stability. On this one only has one nail. This is a bad example because I remember who did this. Okay, typically, if a fracture can shorten on itself, we would want more than one screw here. I apologize for using a bad example. And that would because those screws are being asked to resist an axial load. Whereas in this femoral shaft back here, this fracture is all but perfect. Every edge of the bone is lined up on top of one another. This fracture is not going anywhere. You could do almost nothing to it and you could just leave the nail in. It's not going anywhere. These screws are not being asked to do very much work. The more comminution you have, the more shortening that could happen, the more forces that are going to be seen on those screws. That's when you start adding more screws.
There's also a question about would you use a how do you choose between a cephalomedullary nail versus sliding hip screw for femoral neck fractures? That's a whole different discussion.
That's a great question. It's one that would take much longer to answer than we have time for here. Who asked that?
Short answer is most of the time we won't use a cephalomedullary nail for femoral neck fracture. You'll most likely either use a sliding hip screw or cannulated screws, or you can do a hemiarthroplasty versus a total arthroplasty. Cephalomedullary nails, and most of the time we're going to use for intertrochanteric fractures. And there's a whole discussion of when you would use a cephalomedullary nail for an intertroch fracture versus a sliding hip screw. We can get to that in another topic.
The very short answer is that for intertrochanteric fractures, a nail could do basically every one of the fractures. There are several variants of intertrochanteric fractures that are known to fail with a sliding hip screw. But a sliding hip screw has more precision than a cephalomedullary nail. And so when we care a lot about the neck, we might use that. Locking screws always go through. So Yazan asked.
I already kind of answered it.
Okay.
Any other questions? I think we have 2 more minutes.
Jeremy's making fun of me saying we have time issues today because I talked too long.
I think one of the major benefits of nails are, one, you're being very friendly to the soft tissues, and that's allowing for a lot of vasculature there to promote bone healing. And then 2, you allow the patient to weight bear, and that's very important to elderly patients. You got to get them up, moving around. So.
Tyler asked if we have any thoughts on program directors, thoughts on doing aways. Ooh, that is hard. I would say that the benefit of an away is not necessarily, well, it's kind of twofold. It's for the program, it's also for you. Away rotations give you the opportunity to show that you're more than paper. With the current pandemic, there's so much uncertainty about whether you can, I don't even know if you can. So I would say if you can, then do them. But if the general consensus, and maybe this is what you're asking, if the general consensus from most of the programs is that they're not having students rotate, then nobody's going to hold that against you. You know, I suppose the only positive way of looking at that is you and your fellow applicants are all in the same boat. So no one is at an advantage or disadvantage because of the pandemic.
And Tyler, I don't know if you were here in the beginning. There's this Instagram account, Ortho Mentor. Next week, they're giving a webinar on pretty much that. So I think you have to register for that. But I don't know too many specifics, but that should be a good reference for you guys. So it's 8:30 and they didn't kick us out. So if you want to get into Andrew's question a little bit more, we can. Joe, you want to quickly
Sure.
discuss that?
Okay, so let's see if this works. Let's use this example because it's perfect. A sliding hip screw requires two critical things in order for its mechanics to function. Both a sliding hip screw and a cephalomedullary nail are designed to allow shortening to occur along the bolt, okay? Whether it is this kind of bolt that's going through a nail, or if you had a sliding hip screw with a plate here and a barrel and a screw coming out of it, it's designed to be able to shorten across that, okay? Maybe it's easier to start with the nail.
Yeah.
In a nail, as this proximal segment begins to shorten along the length of the crosslock bolt, one of two things is going to happen. Either this stiff bone along the neck, called the calcar, is going to encounter some stiff bone here along the medial aspect of the femoral shaft, and it's going to squish right there and compress and stop. Or if it doesn't do that, at a maximum, the farthest that this will slide is until this bone hits the nail. That's it. It'll never slide farther than that. There's no way. So the issue becomes, how much can this shorten? Because in this fracture, if you had a sliding hip screw with the plate here on the outside of the bone, and you had a screw going up, if this calcar cortex does not encounter the medial cortex of the femoral shaft, then it's just going to keep shortening and keep shortening and keep shortening. Now, the caveat is that there is something else that should stop that shortening, and that's up top. The top of the femoral neck should encounter the lateral cortex of the trochanter. All right, and so that should stop it from shortening. But in this particular pattern, in a reverse obliquity, this whole segment is going to move. It's going to continue to shorten. Or if you had a standard obliquity fracture that involved the fracture line exited out the lateral cortex here, so that this wall was no longer competent, it could not stop the shortening here, and the shortening here is not going to stop, and so it's just going to keep moving. And that is a result of the angle of this fracture. This is a reverse obliquity fracture. These will shorten to an unacceptable amount on a sliding hip screw. If you had a standard obliquity fracture with an intact lateral wall, that fracture would not shorten too much. It would stop here, or it would stop here. And that fracture could be treated either way. You could treat it with the nail, you could treat it with a sliding hip screw. But dealer's choice, whatever your preference is. But if you have a reverse obliquity fracture, or if you have a fracture out the lateral cortex, or if you have severe comminution here, meaning that this is no longer going to be a reliable stop for that shortening, any one of those three things place this into what we call an unstable intertrochanteric fracture, which means it's going to shorten and shorten and shorten until this finally hits the plate way over here. And by that time, it's not that the femoral head is moving this way. It's really that the shaft is moving medial. By the time that stops, your shaft is almost abutting your ischium, and that's just too short. The abductors lose their function. Patients start to develop a Trendelenburg gait. They'll develop arthritic changes here. It leads to a lot of problems. But with a nail in place, this can only shorten about 1 centimeter. That's it. It's not going to shorten any more than that.
There's also one other situation where you would prefer to do a nail, and that would be if you have subtrochanteric extension of your fracture. So if that intertroch fracture extends down past your lesser and involves more of the diaphyseal, then you're going to want to use it cephalomedullary nail. A lot of these days, majority of surgeons use cephalomedullary nails over sliding hip screws. Part of the reason why is they're just more familiar with it. The sliding hip screws are a little bit cheaper, so if you can get away with doing that in a appropriate fracture, there's great results with sliding hip screws. But if any of those that Joe mentioned, you have to use a cephalomedullary nail. Also, briefly, Joe, we talked about starting points, and you talked about how the Piriformis start entry is beneficial because it lines up perfectly to the shaft, and that is going to be beneficial in diaphyseal fractures because our nail is going to be a straight nail, and that's going to line up straight to the shaft, and we're going to get very good alignment. Can you just point out on that third x-ray there where your Piriformis start entry is?
Sure. So I think it's actually more visible in the second x-ray. So this right here, if you see the contour of the greater trochanter comes up, it forms a tip, and then you can follow it either one of two directions. You can follow it along the superior neck, or you can follow it down. This is actually going posterior, and you're seeing a shadow of a cortical density here to this little shelf. That little shelf is what's called the piriform fossa. Now, I will confuse all of you by telling you there is no such anatomic location as the piriformis fossa. If you look at an anatomy textbook, this right here is called the trochanteric fossa. And at some point in, I don't know, sometime around the time of Dr. Kunchner, they started calling this the piriform fossa, and that just continued in all textbooks. So if you try and find that on an anatomy textbook, you're like, where's the piriformis fossa? You will not find it. It's not a real structure, but this is where we put the nail in, and it's right at that little radiographic shelf.
And since it's that shelf, it looks like it's into the bone, but because it's posterior, it's going to be distal to your femoral neck. So a lot of the times if a resident is putting their start wire, and it's kind of joking, you point out where like an abnormal spot would be on the top of the femoral neck. So if it's right there, you're on the neck, you're too anterior. So then you have to bring it posterior to drop into that piriformis fossa, which is going to look like you're into the bone, but you're just really just dropping down into that fossa.
I wonder if I can just show you guys. Can you see this? Can you see my internet browser? Jeremy, can you see my internet browser?
No, you're still on the PowerPoint. You're just out of...
View share. This one. Can you see the internet browser now?
Correct. Any last questions?
Of course, I'm not going to find anything that shows a starting wire. No, not really. That one's already in. Oh, well. You guys could Google it for a while, and I'm sure you'll find it.
What we'll do is next week we'll find one and show you guys.
Yeah, we'll put an image in the next one. So next week, Jeremy, we're talking about
Not sure.
Yeah, I don't know either. I have the list somewhere, but we'll figure it out. Stay tuned. If you want to know what we're talking about next week, you have to come back.
All right. Thanks again for everybody joining. It's been fun. Have a good night.
Yeah, absolutely. Thanks, everybody.
That was a great lecture, Joe.
Thanks. Stop share.